Hello, my name is Dr. Jungju Park, and I completed my orthodontic residency at A.T. Still University, Arizona School of Dentistry and Oral Health postgraduate orthodontic program, and I'm currently practicing as an ABO board-certified orthodontist in South Korea. I would like to share a case treated during my residency under the guidance of my program director, Dr. Hyun Park. A 17-year-old Hispanic female presented to the clinic with the chief complaint, "I have crowding." During the initial exam, the patient reported having seasonal allergic sinusitis, depression, and anxiety. She had a history of having a nasal fracture surgery. To treat her snoring, tonsillectomy was scheduled around the beginning of her orthodontic treatment. She was a mouth breather as well. The patient presented with brachycephalic face with competent lips. Her smile arc was flat, and she had a slightly low smile line. Her facial profile was convex with obtuse nasolabial angle, and she had a deep labiomental fold. She presented with bilateral endon class 2 molar and canine relationships and a large overjet. The patient had a moderate curve of SPE, but a minimal overbite with an open bite tendency. While her mandibular midline was coincident with her facial midline, her maxillary midline was shifted slightly to the right side. The Bulletin analysis and clinical finding demonstrated the excess in the width of her maxillary anterior teeth. Both of her maxillary and mandibular arches were in ovoid arch form. Her maxillary arch had moderate crowding, while her mandibular arch had mild crowding. A panoramic radiograph at pre-treatment showed normal condyles of good cortication without beaking. All 4 third molars were present, but they were not erupted yet. Cephalometric analysis showed that the patient had a skeletal class 2 pattern with orthognathic maxilla and retrognathic mandible. She presented a normal virgin skeletal type. While the positions of her slightly upright maxillary incisors were still within normal limit, her mandibular incisors were largely proclined. Both of her upper and lower lips were protrusive to the E-line. The ABO discrepancy index score of this case was 27. The following treatment options were provided. First 4 options are comprehensive orthodontic treatment option, while the 5th option was a surgical one. And first option is a non-extraction method using C-palatal plate fixed with palatal mini screws for molar distalization and intrusion. Second option is to include extraction of upper 4s, conduct reciprocal space closure using closing loops, and use class 2 elastics as needed. Third option is to extract upper 4s and lower 5s, close the maxillary space with maximum anchorage using TADs in the posterior region, and perform reciprocal space closure in the mandibular arch using sliding mechanics or closing loops. Option number 4 is a camouflage treatment with class 2 elastics and perform interproximal reduction on both maxillary and mandibular incisors. Fifth surgical option is to include extraction of lower 4s and perform bilateral sagittal split osteotomy for mandibular advancement combined with comprehensive orthodontic treatment. If you're interested in how this case was treated, please go to PCSO Bulletin 2021 Fall Edition. Thank you for your time and attention.